So good morning, everyone, and welcome to this second session here in the Community Connect. I think for those who were, part of the previous discussions, a really interesting one looking at stigma, obviously, which has been like a key priority for community partners. And I think in some ways we see, a lot of there's a nice little link here, I think, with the current session, which is looking at that question of access. When we have barriers like stigma that exist, it is very, very difficult for people with TB to access the services they need. The other side almost to that coin, though, is very much about having a space where communities are supported to generate the demand for new TB tools. It's something that, as a TB community, I think that it's an emerging area. It's something that we need to get better at, get stronger at, and it's really good that we have this discussion today looking at this example of enhanced demand generation or generating demand for TB tools in relation to drug-resistant TB. It's certainly something which is critical in the context of drug-resistant TB, but it's something that we can also apply probably across the broader TB response about generating demand for new approaches, for new perspectives, generating demand for new diagnostics, for new drugs, new regimens, new innovations. And I think that this is like in many ways a common theme here, I guess, for the conference, where a community voice and a community question for pretty much all of the sessions talking about progress and opportunity is: how are we supporting communities to generate the demand to ensure that all people who need it can access those tools, those services? And so it's great today that we have that opportunity to discuss this particular focus. I think I wanted to really recognise TB Alliance for a lot of the work and support taking forward this initiative. This is the second iteration of the Fast Track the Cure, and now we have like a new, I guess, team of graduate country partners to share their experiences and really, I guess, enrich the thinking and the knowledge that we have from countries and from communities on the ground driving this change forward. So today, over the course of the speakers, we have an opportunity to hear from India, from Pakistan, from Bangladesh, and Nigeria. And are we missing a speaker? No, the Nigeria. Okay, fantastic. I was looking and I was trying to link the two together. But so we'll have that opportunity, and I think as well we'd really encourage people to ask questions, to share reflections, because as we said, we think that this is a really interesting, important, and emerging area of the TB response, and there's a great deal that can be learnt from each of the community partners here. So from my side, I'm James. I work for Stop TB Partnership, and have been fortunate to work with each of these community partners through Challenge Facility for Civil Society, and the Fast Track the Cure initiative around looking at demand creation is something that we've tried to work closely with TB Alliance on and find some synergies with the Challenge Facility for Civil Society models for demand creation as well, and it's something that's really worked really well. So just recognising the partnership from the side of TB Alliance there, and the opportunity to share today, and also I'm here to have the privilege to co-chair.
Hi, good afternoon. I'm Dr. Eden Mendoza-Hisey. I'm also the head of Peerlinc, and I'm co-chairing with James. I've been working with the TB space for 10 years and been working with the community for around that time as well, from the Philippines. Over.
Thank you so much. And so I think maybe without further ado, we can sort of move to hear our first presentation, looking at the example from India. We have Anupama here from Reach, and I think that there's a really rich experience where they've been able to work to leverage the huge network of TB champions and TB community champions to really elevate demand creation around drug-resistant TB, tools in that context. So over to you, Anu.
Morning, good afternoon, everyone. One moment. Yep, so on behalf of all of us at REACH, I'm going to be speaking about how survivor-led networks have been driving adherence and helping people with DRTB specifically through treatment pathways. Of course, we're delighted to be part of the Fast Track the Cure Consortium 2.0, like James mentioned, and build on the work that so many amazing partners have done. I have no conflict of interest to report. So John Green said this morning about how so many of us have our own Henrys, and I think that's one of the biggest privileges of doing the work that we've been able to do for the last several decades. And the young woman in the green on the right side of this image is 26-year-old Afreen. Afreen travels about 11 kilometers every morning from her home to the tertiary hospital in Delhi, the capital of India, where every day she speaks to people who've been newly diagnosed with drug-resistant TB. And I think really is that first point of, oh my God, I have drug-resistant TB. What does it mean? She helps them just come to terms with that diagnosis. She helps them sort of look at what's coming next, what's ahead of them for the next few months. And she does this balancing act along with, of course, the medical care that's provided. She helps them understand the regimen that you're on. It's a shorter regimen. It's something that you don't have to be scared of, and so on. So what Afreen, like many other TB champions, has really been able to do is use her own lived experience of TB as a TB survivor and help translate that into very tangible peer support that she's able to provide to people with DRTB every day, literally. For those of you very quickly who are not familiar with the history of the TB champion movement in India, this goes back to about 2015-16 and has evolved considerably, like James said, over the last decade. Today, TB champions educating communities about TB and DRTB. They're working with elected representatives. They're addressing stigma. And of course, they're supporting people with TB and DRTB. What we've been able to do through this particular work that began about 6 months ago is really building community capacity on drug-resistant TB, which, like all of us in the room will agree, is incredibly complex to understand in terms of both the diagnostic cascade and, until recently, the very complex treatment regimens that were the only choice available. What we've done so far is 5 workshops where 102 TB champions have been trained so far. Now, this training is really about combining both knowledge and skills. So one, how do we equip TB champions like Afreen with the knowledge of drug-resistant TB, but also how do we equip them with the skills to take this knowledge to their communities, to really talk about even what is resistance conceptually, right? So the focus is both on their own personal lived experience and their experience as TB champions. And of course, this is followed by a lot of mentoring support over the course of the engagement period as well. The woman in the right image in a dark red sari is Veera Lakshmi. She's a TB champion from Tamil Nadu, a district, state in southern India. And again, like Afreen, every day Veera Lakshmi travels to a health center and talks to people with DRTB. And one of the things we've been trying to figure out in the context of the introduction of the BPAL and BPALM, the shorter regimens, is how does this peer support get operationalized? How decentralized can treatment be made available? Where is that first point of contact? And this remains work in progress that we're trying to understand and will continue to try to understand over the next few months. But basically, in that first contact, the objective of what this broad umbrella of peer support is really, like I said, treatment literacy, what to expect and when to expect it, completing that diagnostic cascade, have all the tests been done, emphasizing the importance of nutritional support and looking at available social support schemes in India and making sure those linkages have been established. And from month 2 onwards, it's really about that follow-up. And it's about providing that emotional support, being that person that is available, whether on the phone or at the health facility, to really reassure and, sort of say, okay, look, you are going to be cured of TB. It is not the end of your life. And I think that's the biggest role that TB champions play. I'm not going to go into each of these questions, but really, I think where the TB champions' role in drug-resistant TB is a combination of providing that information, providing that emotional support, but also because I think very often not everyone can remember that cascade by heart, right? And to sort of say, okay, have you done this now? And have you done that at this point? And to sort of know, and also look at how are things at home. Who else is going to talk to them about stigma, like James said? So whether it's self-stigma or whether it's stigma or discrimination they might be experiencing within their communities. Do they have drugs? Are they having any side effects? So these are, I mean, this is by no means an exhaustive checklist, and it's really driven by each individual TB champion's own intuitive understanding of the person sitting in front of them and how they can help them cope with drug-resistant TB. So just very quickly before I end, some sense of numbers and where we're at. As I said, we've trained what we set out to do in terms of 102 TB champions. Now, these TB champions have so far organized 714 community meetings through which they've educated 16,360 people on both drug-resistant TB, the shorter regimens that are available, and so far about 70 plus people with DRTB have been provided peer support. And this is work that we will continue to build on. And I think what has been evident so far in terms of the peer support piece, I just want to quickly say before I end, is I think one of the things we want to understand is what is that experience of the shorter regimens? And this is some documentation work that we hope to be doing over the next few months. And of course, I also want to say that we will be having an opportunity to build on this work and expand on it through the Unitate supported upcoming Respect project led by Stop TB Partnership. So I think with all the synergies that we're able to pull together, this is really a great opportunity for us to build community capacity on drug-resistant TB. And we're very grateful to be able to do this work, and a big thank you to TB Alliance for making this possible. Thank you so much.
Thank you so much, Anu, for the reflections. I think it was lovely to sort of hear a little bit about the story through the eyes of one of your TB champions as well. And also, as you mentioned, I think it's what's really good here, both in the context of India and from our next speaker in Pakistan, is the opportunity to really build off this work and to take it to scale, looking at the broader DRTB response generally and that need for demand creation. And so from the side of Stop TB, we're excited to continue working with you, working with other country partners who are scaling this up through that Unitate project on demand creation for DRTB. Now, for the next presentation, I think we have a video, and it's okay. It's about to be, which will be played. Unfortunately, Kinz, who was going to speak, is still in transit, but will be joining shortly. We are represented by some of her colleagues on here, so if you do have questions, there are colleagues from Dopasi who will be able to answer those. But I think Kinz is going to share a little bit with us about some of the digital campaigns and the link here to the demand creation around DRTB. So take it away, Kinz.
Thank you so much for joining us for the session today. I'm Kinz Ul Eman. I lead the Dopasi Foundation in Pakistan. Of no conflict of interest to declare. Most of us in this room turn to internet for answers. A new recipe, a health tip, even a flight update. But millions around the world still can't access the right information when it comes to TB, even when their lives depend on it. Drug-resistant TB is curable, and now there's shorter and safer regimens. Yet people still ask what sources work. They trust misinformation and delay care because the system hasn't reached them. That's where we began this journey, using the same digital tools that connect us globally to bring truth, access, and accountability to TB care locally. Before we talk about digital campaigns, I just want to take a step back and reflect on the lived realities that make these campaigns so critical. What you see here are not just words. They represent the daily barriers faced by people affected by drug-resistant TB. These are not abstract challenges. These are real experience that communities live in silence. Many people with drug-resistant TB travel a long distance to reach DRTB management sites, only to face out-of-pocket expenses, encounter providers reluctant to prescribe new regimens, and crucially, people affected by DRTB often have no safe or trusted medium to raise their concerns, to share their feedback, or even ask for help. This is why the Dopasi Foundation created and now hosts an enhanced version of the One Impact platform, voted by the Stop TB Partnerships Challenge Facility for Civil Society, a digital bridge that connects these voices to decision makers. Through One Impact, communities can report barriers, access accurate information, connect with peers, and hold the system accountable. It's become a medium to connect, communicate, and raise voice. So as we move to the next part of the presentation, I'll show you how we turn these voices into data that led to dialogue and eventually digital advocacy through One Impact hosted by Dopasi and the campaign built around it. Pakistan is 5th highest DRTB burden, yet majority of our population is unaware of new shorter regimens like BPAL, BPAL-M, that they even exist, and they're relying on conventional knowledge. What holds us back isn't the disease, it's the disconnect between the knowledge and the access. To bridge this, Dopasi built a national community-led monitoring ecosystem, starting with the Challenge Facility for Civil Society, strengthened now the DRTB component included through Fast Track to Cure, and it's being scaled up and expanded through the Stop TB Partnerships Respect TB project, supported by UNITED and Challenge Facility for Civil Society 2025. The core of the system is a digital platform that connects people with care, lets them report the barriers that they face, and bring their feedback directly to the decision maker. As donors pivot and national programs prepare to scale up shorter regimens, community demand generation, community awareness, and community engagement has become a race against time. The CLM platform works on a simple principle. People need knowledge, navigation, and voice. Through the platform, users can learn about their rights, get practical information about diagnosis and treatment, access real-time maps of all the gene expert sites and the treatment sites, like where they can get diagnosis, where they can get treatment across the country. There's also built-in AI chatbot for navigation. We have WhatsApp-based peer groups. We have app-based peer groups for supporting the community and for reporting barriers. It's not technology, and it's not for technology's sake. It is community designed, locally contextualized in the local language, and is operated by TB survivors and our community volunteers who know what exclusion feels like, who have been through this journey. And these include the IEC materials, expert messages, videos, frequently asked questions, and that too in the local language that is understandable by the communities that the platform is designed for. The strength of our CLM system is that it works both ways, bottom up and top down. At the grassroots level, we have trained over 40 champions who have reached 10,000 community directly and over 25,000 people through outreach under Challenge Facility for Civil Society and FTTC. We have nearly 30,000 active users of the One Impact platform at the moment, with the community health workers that have been trained on CLM dashboard. They recognize and respond to the reported barriers. At policy level, we have developed DRTB landscape analysis and are developing advocacy packages engaging media, celebrities, policymakers, parliamentarians. Since the launch of the One Impact in Pakistan, we have seen over 600 new registrations. 30% of these are DRTB survivors. These are not just numbers, these are individuals who have taken the courage to step from being patients to becoming participants and from being treated to being heard. Through the platform, 170 questions and barriers have raised regarding DRTB have been addressed and resolved. We don't stop there. 3 dedicated DRTB peer groups have been formed for providing the support as and when required. Perhaps one of the most inspiring achievements is that DRTB survivors are now taking the lead themselves. We now have the technology to see every heartbeat on Earth. It's time we listen to the voices behind those heartbeats. Thank you so very much.
So thank you very much, Kinz, for joining us. I guess it makes sense for it to have been a virtual presentation for a virtual thematic sort of intervention as well. So if anyone was not able to make it, it probably works for Kinz. What I think was really important here is like the complementarity that we see between what Anu spoke to us about from the context of India with a lot of the peer-to-peer work and really the hands-on and interpersonal engagement from TB champions, and the opportunities to complement that with innovation and technology. And again, this idea of this demand creation for this project was about demand creation for DRTB tools, but we also are seeing demand for access to innovation and access to technologies. And the fact that communities have a role to design these, to adapt these, to implement these, and to scale these. And those numbers, I think, that we see there from Pakistan are really significant. The fact that the experience for DRTB is such a such a burdensome journey, a very challenging journey for everyone going through it. The person with the DRTB first and foremost. The fact that you have this opportunity now to provide that a different medium for support, a different medium for reporting barriers to access, seeking information, seeking access to services and support is something that we really need to use the opportunity to take more use of. And I think that there was a point, I think on the second last slide, looking at the number of recent registrations for One Impact. At a global level, there's close to 300,000 people using this platform for community-led monitoring, close to 300,000, across now 30 countries. And this was a project that's recently sort of kicked off, but having 600 new registrations where I think it was greater than 30% were DRTB. And one of the things that I think that, is becoming an increasingly common area and priority for TB community partners is to recognize that the additional challenges that people with DRTB face, and providing a platform where there can be increasing focus and engagement of people with DRTB. And that's something that's critically important when we're trying to both support people through their TB journey, and as a key part of that, create the demand for those DRTB tools, because who better to ask for it, to demand it than people with DRTB themselves. So I think, just to really thank Kinz and the team from Dopasi. I know that we have representation up here from them as well. But now we're going to switch the chairing roles, and you get a different approach now.
Okay, thank you, James. So now we've heard from India and we've heard from Pakistan what they have been doing in their countries. So the next speaker will be from Bangladesh. And this time we are going to listen to how data collected through community-led monitoring is being used to shape policy decisions. So now I'm going to call on Dr. Khaled bin Yousuf for this presentation.
Good afternoon, everyone. I am Khaled bin Yousuf, working from Nari, Bangladesh. So from Nari, we're working from the CFCS round, SWP partnership round 10, 11, 12, and now we are very honored to be a part of the fast track to cure initiatives. So we are here to discuss the incredible breakthrough of BPALM, the short all-oral DRTB regimen, but a medical breakthrough is only complete when it's available, accessible, and acceptable to every person, that's those who need it. So here, my presentation, Data by the People, Community Monitoring for Equitable Drug, is about ensuring the shortest cure leads to the shortest path, and we achieve this by empowering the community to be the system's accountability partners. So the conflict of interest, I have no conflict of interest to report. So the DRTB context in Bangladesh, the seventh globally high burden countries of the world among the 30 countries, and also the MDRTB rate is much higher than the other countries. So in last year, 2023, and also in the new report of the WHO 2024, 0.3 million people TB cases identified, and among them the most problematic things is only the 2 in 5 people with drug-resistant TB are diagnosed and treated. So among 7,000 people, we have only 2,729 people that has been diagnosed by the DRTB. So this is a very much needed, because we are working with the TB Alliance with this project particularly to focusing the 1 million people who are mainly facing the high stigma and misinformation. So as the community peoples are so much vulnerable due to the stigma, and also that's why due to these barriers they have made the starting the BPALM treatment delay. And we have last year we have prepared the TB legal environment and human rights scorecard with the CFCS 12 round, and with this TB legal human rights scorecard, we have identified some gaps that's mainly properly for find out the non-discrimination and access to comprehensive support in here. So this is why community data matters. When the legal framework is weak, when we found this, so the people themselves must become the human rights monitors to ensure the new treatments that's the accessible equitability. So with this FTCC cure, we are mainly focusing on the accountability, that's empowering the community to monitor the rollout. So in the last TB legal and human rights scorecard, we have found out that some gaps in our systems, like the non-discrimination, that is stigma, and also the right to comprehensive care, that is the support service, and the accountability. So that's why we are trying to raise the community-led demand creation and monitoring to ensure that the effective BPLM 6 months, this is the effective deployment in the areas that we are working. So there's the pictures of our community, and we have prepared some stories with the survivor and the TV champion that is disseminated to the people to make them aware about how can then increase the community demand creation. So the first one pillar is the community-led demand creation. We have prepared ambassador network, like 30 ambassador networks in the different community that is included by the TB survivors, community health workers, and the DOT providers. And we also regularly provide them support. They have make some support groups, and with this support group, we have make a linkage with them with the National NTB program, and by that we have also prepared some ISC materials, that is the culturally appropriate messaging, video leaflet, and also some community events. So these first things increase the awareness and demand to the community that are working. That is our first pillar for making this possible. And these things, like we have also created some making referral loops with these ambassadors who are working with us. So we make a structured referral system that is linkage with particularly the local health facilities. And also we are quarterly, regularly trying to track the number of the individuals that is referred to the TV services and the give exposure to our awareness campaign. So with this all efforts, we find out that the informed demand reduces the loss to follow-up and measurable service is uptaken by this community. By the second pillar is the core mechanism, where we community scorecard, we like approaching this process like there is the data collection first, then the scoring, and then there is some dialogue with the community people. Then there is some joint planning and action plan up with the NTB for the sustainability. And then we regularly follow up these things, because without the follow up, this is not possible to regularly find out the things that what is happening here. So we have find here that the stigma-free care, that whether the does counseling respect the patient's dignity, also the psychosocial support is available, and the accountability. And with these things, the impact is that we provide the data pinpoints for the legal human rights scorecards. Standards are failing to local level. So this is the case study. So with this, all of the study, we have regularly meet with the National TV program, and the scorecards with these districts was find the challenge that the new regimens, the stigma-related dropouts, and the need on the ongoing psychosocial support for the BPLM patients. So with this support, the 30 ambassadors network that is we have established, that is the with collaborative support with the NTP, and also with this support, NTP recently prepared the updated the national guideline that officially began the national 6-month oral regimen, and the health worker also get the treatment. So that's why they provide the new training curriculum that is more effective and the shorter and safer retrieving at scale. And with those ambassadors that are working, that are provide the community-based awareness, run support groups, and offer the peer groups, and also that's bridge the gap between our local health community clinics and the community, ensuring patients receive accurate information on the ongoing support they are getting. So they like these ambassadors working as a local information hubs. That's they're working to combating the misinformation and also documented the patient's experience with the BPLM. So with this, all of the data and the decision and policy makers, we have got all the community feedback mechanism, and with the community feedback mechanism that we are collecting for the different channel like online, physical boxes, there, and also we analyze the data that we are getting from them, and also there are the individuals who get the services like diagnosis, treatment, and engage with the BPLM ambassadors. So after that, we have making a meeting with the policy makers like NTP staffs, community leaders, and provide them the result that they want to show. And with this, now we're doing the high-level advocacy meeting, and now we're trying to doing the policy things and budget influence things. By that, the gaps that we identify, that is measurable improvement in access and accountability delivery. So in last, we can say that Nari Maitree, this model demonstrated that community monitoring anchored by the TB legal environment and human rights scorecard is the foundation for an equitable and sustainable for the DRTB response. So we have empowered the community to not only demand treatment, but to given the quality and human right compliance. Our next step is to sustainability plan with the NTP to fully integrate this model, ensuring long-term adherence to human rights standards. So for the new cure to succeed, we must make system accountable to the people they serve. Thank you, everyone. 6 months max. So we hope to make a sustainable equitable access to everyone. Thank you, everyone.
Thank you, Khaled. It's a very good presentation, and you've done a lot, and I'm going to highlight two things from that presentation. One was the fact that the demand generation is connected to referral systems, making sure that the patients are actually linked to the facilities so that they don't get lost in the local health system. I think that was one of the issues that we were also facing in the Philippines when we did a lot of demand creation activities, but a lot of patients were not still reaching the facilities because they don't know whom to talk to and they don't know how to navigate the local system. So I'm very glad that Bangladesh has covered that. And the other one is that the fact that they were getting a lot of data and providing feedback to the government and making sure that these policies or this data is converted into policies or policy changes. That is something that we also have a lot of challenges in the Philippines. There's a lot of feedback, but there's no policy change that's happening. I mean, despite the fact that we have done a lot of monitoring, but the monitoring is done by health workers rather than the community or the people who have actually lived their experience and have experienced the navigation of the health systems, and we haven't actually listened to all of them. So I'm also glad that Bangladesh has done that, and hopefully other countries will follow suit. So now I'm going to move to the last speaker because I think we've missed one of the other one from Peru. So now we're going to listen to Nigeria and how they did the radio jingles and talk shows. So take it away, Theresa.
On this segment, I'll be speaking about community media-driven demand and accountability. I'd like to say that I have no conflict of interest in this report. Amplifying community voices in DRTB response. The Civil Society for the Eradication of Tuberculosis in Nigeria, also known as TB Network, is a not-for-profit organization established in 2009 and registered with the Corporate Affairs Commission in June 2010. The network has over 600 registered CBOs across the 36+1 states in Nigeria. TB Network represents the voices from the community for the community. And on the fast-track the care intervention, we work in Katsina and Kano State. The FTTC project in Nigeria, which is a fast-track the cure, aims to strengthen community engagement and demand for BPAM regimen through awareness, community-led monitoring, and evidence-based learning to improve treatment uptake and outcomes. The fast-track the cure project aims to strengthen community awareness and community demand for DRTB treatment, address stigma and sociocultural barriers, foster community accountability, and improve treatment uptake. Understanding the power of local voices in TB response. The challenge in Kano and Katsina State is a deep-rooted sociocultural norms, limited awareness, and gender barriers that has helped to shape health-seeking behavior in both states. So we performed a baseline assessment to understand these gaps. From the findings, we saw that there's low knowledge of DRTB treatment and options, myths and misconceptions, women-limited decision-making power, and then stigma and fear from having an open discussion about their status or disclosing that they have DRTB. So from the baseline, we got quotes saying, "When I heard the jingle in Hausa saying DRTB is curable, I told my husband to return for treatment." Some of the findings from the two states, we had the demographics, 157 respondents, 79 key informant interviews were conducted, 78 focus group discussions, 82% were male, 18% were female. The target audience were those who have DRTB and their caregivers. The key informant interviews were community health influencers, policymakers, DRTB survivors themselves, and then healthcare workers. The challenges: more radio jingles and outreaches, high workplace stigma, social mockery, high transport costs to facilities, lost income due to DRTB, limited exposure due to mobility and cultural barriers. We also heard quotes from the respondents saying, "My co-workers stopped sharing food with me." This is a mail from Katsina local government. "My husband's family said I brought costs to the family." This is a female from Funtua local government. Why do we want to use radio to break silence and build support? It is the most accessible medium to have or get information. It is trusted by the community members, especially in rural areas. It enables dialogue in local language, especially the Hausa, leading to reduced stigma, misinformation, and all of that. The approach we want to employ is to partner with communication experts, local radio stations, to develop and broadcast radio jingles that will be culturally sensitive to avoid reinforcing stigma, emphasize that DRTB is curable, and encourage survival to seek care. We also want to feature TB survivors so that their testimonies can inspire and reduce fear in the community. We also want to see that at the end of the day, there's expanded listenership and community dialogue, shift perceptions from silence to solidarity, strengthen community accountability through increased awareness and reporting. In the course of this work, we've also been able to reach TB survivors, DRTB patients, to access household economic strength, leverage on household economic strength, and also improve their diet. We also provide some kind of support to the staff to be able to access care, to be able to be more supportive to DRTB survivors. The project has opened the space for open conversation or discussion about DRTB as we push to improve the health-seeking behavior in both states. Thank you.
Thank you, Theresa. Actually, I'm very happy to listen to this lecture or presentation because this is the first time I've listened to a presentation where they've done an assessment including a gender-related barrier assessment. And as an advocate of gender equality and women empowerment, I'm so glad that before they even created their initiative or their activity, they did an assessment first and made sure that it's culturally sensitive and gender sensitive. So thank you very much for that presentation. And if there are we going to move on to question and answer?
Yeah, thank you. There are some moving presentations and it's really, thought-provoking. Just, I would like to know a little bit more about from the speaker from Nigeria. Like, when we talk about community, media, it's a very, impactful tool. But, there is one point here, like, how to make it more self-sustaining, because a lot of the community medias are, in a situation of crunch. So in that regard, like, how can we, make it our, program self-sustaining and involving that community? So if she could throw some light on that regard, I think that would be helpful for us.
I think, thank you so much for that question, Paranjo. And I think, no, you're absolutely right. Community media has always had low resources at the best of times. And I think now it's gotten even harder. Some of the non-financial ways in which we have tried working with media, particularly in the TB context, have been centered around, first, capacity building itself. I think just building capacity within, for example, community radio stations, which is something we've done in the Indian context in the past, to understand TB, to understand the local TB and DRTB contexts, and really look at how we can bring resources to them in the form of, let's say, identifying the right resource persons, making sure that people are available. Survivors, for instance, can be brought to radio stations to speak. So I think it's about, to be honest, it's not a replacement for financial resources. And at the end of the day, that's imperative for any media entity to survive. right? So it's not a substitute, but these are stopgap measures in which we can sort of try and sustain that interest. And I think we always say about media, right? Once you get them, the objective is to get them hooked onto TBs, to get TB onto their radar, which is something we've done in the past with our ongoing media fellowships as well. So how do you get that first interest in TB and DRTB? And then how do you keep finding creative ways to sustain it even without financial resources? Thanks.
Would you like to respond to that as well?
I think Akshay
Akshay?
So I'll just like to add Nigeria's perspective actually, because so I'm Akshay and I lead FTTC, and unfortunately they couldn't attend here in person. But I think the use of radio jingles is also very context specific for the two states that they are focusing their work on, especially because there are strong gender norms there. So women do not even step out. But the way they are planning on going about this is that they at least have access to radio. So the whole idea behind doing a baseline assessment was to learn the language in which they can communicate better to the audience as well, and to women and men. So they will have these very context specific, and purely because this is something that is very easily accessible to most of the population. Cell phones aren't, television isn't, but a radio is something that will help them in reaching their target population, more or less more context specific wise. But yeah, this is something that it's tried and tested, and hopefully will work for their specific population. Thank you.
So can I make a brief comment on this?
Sure.
Thanks. So with your permission, Madam Co-Chairman, I'd like to digress a little on this. In Pakistan and most of South Asia, India, Pakistan, Bangladesh, we have TB management units and we have PMDT sites for drug-resistant TB. Now, the PMDT sites may not be in every district. So, suppose there's one for every 3 districts. Then we should be very careful by generating demand, because we might create demand for services which don't exist in that district. And remember, a district of South Asia is like a country of Europe in terms of population. So I think we need to just have that thing at the back of our minds. Otherwise, we're just creating an unmet demand. Thanks.
Thank you.
Just respond.
Yeah? Okay.
Thanks. Thanks so much, Dr. Kazi, for raising that. I think one way to look at this unmet demand versus, this quandary is really to simultaneously also invest in advocacy around, let's say, social protection, right? How do we build travel support for someone with DRTB to travel to a health facility? Or how do we bring drugs to the doorstep? How do we incentivize maybe community volunteers to deliver drugs? So I feel like these go hand in hand. And in some ways, it's a chicken and egg situation. So the absence of services should not prevent us from advocating for them to be there. So I just wanted to flag that. Thank you for raising this.
Okay, thank you. Are there any more questions from the group?
Thank you.
Okay, wait.
Oh, I'd already gotten the mic. Sorry, I'm right here.
Okay.
Okay, thank you. So my name is Tapio Akujinga. I work for a civil society organization, and this is very critical to us because, we need to engage communities on TB if we are ever going to end TB by 2030. So my question goes to Anu. I just wanted to find out, in terms of your messaging on diagnostics to MDR TB or patients, what messages are you disseminating on diagnostics? I presume the algorithm is they first of all get the normal TB test and then get the DRTB test. So what are you saying to them? And I also want to find out what has been the impact of your intervention. Thank you.
I'll take the second tougher question first always. I think I will say that in terms of impact, I think we're premature because we're about 6 months in. But what we have seen in the past is by building community capacity on DRTB among both individual TB champions and survivor-led networks, that we have many such networks in India, is really looking at is really trying to build a base for how this work can continue in the absence of projects. And I think that's where we hope the impact will be in the long term, but it's early days to talk about that. Coming back to the question on diagnostic cascade, so in India, we ideally do upfront NAT. So part of what the TB Champion does in collaboration with the NTP team is really looking at is that entire cascade complete? Has samples been sent for line probe assay testing? Has pre-treatment evaluation been done because it's drug-resistant TB and there could be other complexities even with the shorter regimens? So it's not so much about duplicating the health system's role, but working with the bridging the health system role and peer support to make sure that the person with DRTB is aware of everything that needs to be done. So that, because very often what we find is people are not aware that they've given a sample and the result hasn't come, for instance, right? I mean, a very small example. You give a sample 6 weeks ago, and you're still technically awaiting that result, but it's not come. So unless they have that knowledge and that information, right? I think that's part of what we're trying to do, is to provide that treatment literacy around the diagnostic cascade. Thank you so much for your question.
Thank you.
Okay, just a time check. We have already exited by around 4 minutes or 5 minutes, and I think they'll be using this room. So if you have other questions, I think the speakers would be available for questions. And you can just take it outside of the conference room. I'm sorry, but I think the next session will be starting very soon. So thank you, everyone, for attending.